I was wondering about claudication, and I have full metal jacket, I think they call it, and but I walk every day, and generally do very well. But some days it's a huge struggle, and other days it seems like I fly through it. Same course, maybe same treadmill, or possibly same trail, same time of day. And I'm wondering, is there a rhyme or reason as to why some days I don't struggle and other days it's a huge struggle?
That's a really good question, and one that we as physicians, when we hear a question like that in patients that have had a previous PAD treatment, in your situation, it sounds like you've had a couple stents placed, and a patient has continued leg pain associated with activity, or what we call intermittent claudication, exercise or activity-induced leg pain, which frequently, but not necessarily, can be from a vascular obstruction. So the first thing that I would wonder, knowing that you've had previous intervention, is number one, what studies have been done to exclude your persistent leg pain in terms of an ABI or a pre and post exercise ABI, because all leg pain is not necessarily vascular in nature. Sometimes what happens when we get focused in on a patient that has leg pain and we've treated them from a vascular standpoint, sometimes we take our eye off the fact that, patients do have arthritis. Patients do have sciatica. Patients do have neuropathy. So we sometimes have to take into account that, okay, we've treated a patient with vascular disease, successfully treated, but let's not eliminate the other things from our thought process. The other thing that I would just mention, go ahead. It looks like you wanted to add on to
I
something.
was going to say, even though I've had all that, I am blocked again. I have restenosis. So I know, I mean, I shouldn't say I know because I'm not a scientist, or, I don't have special powers, but we know I'm 100% occluded in my SFA.
Okay. Okay. So certainly we now know that that's certainly something that can contribute. And that's why follow-up is important. A lot of the things that we have for treating certain vessels are not 100% perfect. We don't have the magic bullet yet. That's why we keep doing the research to try and find out what's the right medicine, what's the right device, what's the right approach to risk factor modification. If we had a 100% magic bullet, then everybody would be getting that magic bullet and somebody would have won the Nobel Peace Prize for medicine. It's not me, it's not any of us so far to date. But the other thing I was going to mention is when leg pain is varied like that, you mentioned sometimes you do well, sometimes not so well. That makes it a little bit harder because the typical claudicant patient has this cycle of walking, pain, rest, and relief. Walking, pain, rest, and relief. And it's usually at very predictable distances, with the exception of maybe if you're walking up a hill, those symptoms may come on earlier. So even though we know you have vascular disease, you've had it treated, the stents or the interventions that you've had done before have not, things are occluded now. We still want to be mindful of the fact that, okay, there are patients that can have leg pain for another cause. And then it always comes down to whether or not your lifestyle is limited. We see patients frequently that have more mild symptoms, still have PAD, but they would have more mild symptoms from the standpoint that they may not necessarily be limited, or they may be limited for some other reason. They may have bad emphysema, for example, and they have to stop walking from here to there because they get short of breath rather than the leg pain. So that's why I mentioned before that it's important to ask the very specific questions that get to the heart of the matter, because it's one of those things that leg pain can be from another cause, and let's not lose focus on the fact that patients with PAD can have other causes of that leg pain too.
Marcia, is it the leg cramping that slows you down at a different time and place every single day? Or is it something else?
It's claudication. It's claudication. I mean, some days I can get out there and I just feel like, you know, the world is mine. I got this. I can walk through. I mean, I always have pain, but I walk through it. And other days I just think, how am I going to get it done? You know, this hurts bad. Can I get through it today?
Right.
Well, and that's
So-
a really good point to make. You mentioned that you kind of walk through the pain. That's, you know, the old phrase, no pain, no gain. A lot of people get concerned when they have that pain and they feel like they're making things worse if they continue to walk. And really, that's not the case. We encourage people to walk to the point of pain, pause, walk again, pause, walk again. And the more you retrain those muscles to work on less oxygen and less blood, you're encouraging building those collateral vessels, which are critically important for patients that have either failed some type of intervention or maybe aren't candidates for intervention. So you're not going to hurt anything, and you certainly will be helping things by continuing to walk.